Hello and a warm welcome to this Allergy UK Masterclass hosted by myself, Holly Shaw, Clinical Nurse Advisor. Today we will be talking about eczema, and this is part of a series during National Eczema Week to raise awareness about eczema and atopic dermatitis. So I work as a clinical nurse advisor for the patient organisation Allergy UK. I have both a personal and a professional interest in eczema, having eczema myself and two small children with eczema. Atopic dermatitis, or eczema as it's more commonly known, is a very common skin condition affecting about 20% of children living in the UK. So 1 in 5 children have eczema. And as healthcare professionals, you have a key role to play in educating and supporting patients and families living with eczema. And it's hoped during the course of this morning's sessions that we will be able to support you in your knowledge and learning to better understand the condition and improve your knowledge and awareness of how you may improve patient outcomes back in clinical practice. So if you've attended an Allergy UK Masterclass before, you'll be familiar with the work we do as a patient organisation. But for those of you who are new to Allergy UK, I'd like to take the time this morning during a few short slides just to explain a little bit more about what we do as a patient organisation. Next slide, please. So as an allergy charity, we provide support and information to people living with allergies, and we cover the breadth of allergic disease. So not just eczema, but food allergies, venom allergies, drug allergies, and everything in between. With a leading patient charity, we cover both the non-IG and the IG spectrums of allergic disease. We have an in-house clinical team made up of nurse specialists and dietitians, and we're able to support colleagues throughout the organisation in lots of different work activities. Next slide. So our vision at Allergy UK is that no one should die of allergy, and we want everybody to take allergy seriously in the UK. And our goals as an organisation include education, research and influence, and they are a golden thread throughout all of the work we do. Next slide, please. So why do people need patient organisations like Allergy UK? They need us because allergies are on the rise, and there is a big gap in the education that can be provided by healthcare services. So people will turn to allergy charities for information, advice and support. And this will be across a wide spectrum of disciplines. So this might be members of the public, this might be healthcare professionals, this may be organisations like school, educational facilities, childcare that come to us for advice, support, guidance on practice. We hope to raise awareness of what it's like to live with allergies. Allergies are very common now, and most of us know somebody that has an allergy. But for those people that don't, it's really important that we really advocate for those people living with allergies and those in the allergic community. Next slide. So within Allergy UK, we run a helpline, and really this is the golden crown of services we offer. This is staffed by trained support workers who are able to engage with members of the public through the telephone helpline, through web chat, through emails to answer questions, share knowledge, share information and signpost to all the wonderful assets we have on our website. And over the last year, our impact report has shown that over 743 contacts had issues with accessing treatment through the NHS. So there is barriers out there preventing people from getting the care and information they need. And we know that that has a significant impact on a person's physical and mental well-being. And over 600 of our callers had mental health concerns and issues relating to their allergic conditions. And we sought over 300 contacts of people wanting information on private referrals because they were experiencing access issues to NHS allergy services. Next slide. So on our Allergy UK website, we have a real amazing suite of information. This is not only in written form, but in videos, in podcasts. There's sections for healthcare professionals as well as for members of the public. And the health literacy for the information provided is pitched appropriately. All of the information we have is accredited using the PIF accreditation scheme, and people are drawn to the website in large numbers, as this slide shows. And people are able to follow us on our social media channels. We have a platform on Instagram, and we find that really valuable in connecting with the allergic community. Next slide. Allergy UK has launched a national campaign, and it's one we're extremely passionate about at Allergy UK, and it's reflective of the most important things we have learned about how people are living with allergy. From the research we've done, through people we've spoken to, from focus groups, and through contacts of members of our allergic community, we are able to campaign for better quality services and services at a local level within primary care. If you'd like to know more about this particular campaign, then please do seek that information from our website or social media pages. Next slide. Next slide, please. So not only do we work with members of the public, we work across a variety of platforms to ensure that allergy is advocated for, particularly in education and the food business arena. We work alongside our peak professional body, the BSACI, to improve allergy care, and alongside educational influences like Ofsted and the National Institute of Clinical Excellence, often contributing to different consultations they may have running with regards to care of patients with allergic conditions and diseases. Next slide. So for your time today, you will be able to claim some CPD points for each live session that you stream or listen into. And we will be able to provide some written evidence for your professional portfolio in a certificate, and we issue those generally about three months after the live event. And we also have this information on demand for any colleagues that may be interested on the Allergy UK website. Next slide. So without further ado, today's agenda is looking really, really exciting. We have three amazing clinical experts here today to share their knowledge and expertise with us. So the first session is going to really lay the foundations for a great understanding of what eczema is. We'll talk a little bit about management, back to basics, and Dr. Growell will be presenting some case studies. This session will be followed by a link between eczema and food allergies, a conversation that often comes into conversation in clinical practice. And hopefully after listening to Professor Carsten Floor's explanations, you'll have a greater understanding of the link between the two diseases. The last session will help cement all of the theory into practical elements that you can take away in supporting patients with regards to education. And at the end, you will have the opportunity to ask questions to a live panel of clinical experts. Anything that you think about during your presentation, anything from clinical practice that you'd like to ask, we're here to answer your questions. Next slide. So in order for you to do so, if you could kindly log into slido.com, and if you add the passcode #AUK and today's date, that will allow you to pose your questions. So please, whilst you're listening in this morning, just log in on your phone or log in on your computer, and we look forward to receiving your questions in advance of that live Q&A at midday. So without any further delay, it's my pleasure to introduce our first session of the day, which is understanding the basics of eczema with the bonus of some real life case studies. So I'm going to hand over now to Dr. Anjum Growell. Thank you.
Hello, everyone. Welcome to the Understanding Eczema Back to Basics session of this Allergy UK Masterclass. My name is Dr. Garewal. I'm a consultant pediatric allergist and I work at Sheffield Children's Hospital. And I thank Allergy UK for inviting me to talk today. My background is pediatric allergy, but there's a significant overlap between pediatric and adult eczema. So I hope today to be able to present to you the burden of eczema, the prevalence in children and somewhat in adults as well, the pathophysiology and triggers for this condition, management guidelines, and case studies, which will help us look through some of those management points in more detail. So to start off, eczema or atopic dermatitis is a chronic inflammatory disorder of the skin, which is associated with intense itching, recurrent lesions with redness, blistering, oozing, crusting, scaling, thickening, and color change of the skin. Diagnostic criteria do exist, and the NICE guidelines suggests to diagnose eczema when a child has an itchy skin condition plus 3 or more of the following: visible flexural dermatitis, which mainly means eczema involving the creases, such as bends of elbows or behind knees, or in younger children under 18 months of age, it would tend to involve visible changes over the cheeks and extensor areas. Or if you cannot see these changes at the time when you examine the patient, if they describe or show you photographs of similar lesions previously, and if they've had dry skin in the last 12 months, and often these patients would have other atopic conditions such as asthma, allergic rhinitis, or there'll be a history of atopy in a first-degree relative. And again, most often the onset of symptoms is under the age of 2 years, which would help with the diagnosis. Practically, if you find a patient who has chronically itchy, dry skin with areas of redness with broken raw skin, most of the times it would be eczema, especially if it starts around infancy and there is a personal or a family history of atopy. Just to be mindful, eczema can look different in different skin tones. So in Asian, Black African, and Black Caribbean children, eczema can appear in a different manner so that the flares can look more dark brown, gray, or purple rather than red. And these patients can have involvement of extensor surfaces rather than flexures. Eczema can also be more severe in these ethnic minorities and have different patterns such as discoid or follicular. There's a number of websites, including the ones I've included on the slide, which can guide you to appreciate the changes in these skin conditions. Also, eczema pattern is different at different age groups. So in babies, the irritated skin is often concentrated around the face or around the mouth. And in toddlers and children, you find there's more eczema affecting the flexural areas as well as the feet. And as they become adults, the irritation is more concentrated around the hands, the feet, the head, and the neck region. So it shifts depending upon different age groups. In terms of prevalence, about 1 in every 5 children has eczema to some degree, and 2 to 8% of adults do as well. And the morbidity really depends upon the severity. So mild eczema, which is the most prevalent, about 80% of children with eczema will have mild involvement, which means they will have intermittent redness, drying, or itching, which would be infrequent, which will probably not affect much of their daily activities or sleep. And then moderate eczema would be another 18% of our patients, where they have frequent redness, drying, itching, and excoriation of skin, sometimes leading to thickening. And they can have some disturbance to their sleep as well as their daily activities. Severe eczema, while less common, only 2% can cause significant disruption to quality of life for the patient and their families. And these are the patients where they have incessant itching, oozing, crusting, bleeding, and extensive involvement of skin lesions. What do we understand of the reasons for having eczema? It is multifactorial and quite complex. We know that there is a genetic prevalence to it. We also understand that there is an immune deviation so that the T helper 2 pathway is triggered, which means there's an increased inflammatory mediator release and increased IgE in a lot of cases as well. We do also know that the skin barrier is defective and dysfunctional so that there's more water loss, there is less moisture retained, and there's a mutation in a key component called filaggrin. Abnormal microbial colonization also plays a big role. So patients with eczema have more Staph aureus or yeast on their skin compared to normal skin. And we know that there's a strong psychosomatic influence which almost goes into a vicious cycle. So if I were to demonstrate this to a patient, these are some helpful diagrams that I use. On the left is the skin barrier, which is produced from a number of layers of corneocyte cells. And these are bound together by the filaggrin protein, and they are coated with a lot of lipid and moisturizing factors. Altogether, this produces a strong brick wall-like structure, which bounces off external allergens and irritants, and therefore protects the skin and the other surfaces, such as the surfaces that come into contact with most of the environment. However, when you look at the skin for a patient who has eczema, the same skin barrier is much weakened, so that the filaggrin mutation causes a reduction or deficiency in the bonding mechanisms. The lipid layer is reduced or absent, so the bricks have fallen apart and there isn't a strong barrier left. So the allergens and irritants can penetrate right through and cause a significant inflammation and disruption. And also the water is lost. So the inflammatory pathways, including the Th2, are activated by this mechanism, which leads to a further reduction in the skin barrier. What triggers flares in eczema? And these are quite difficult to pinpoint, as there's a huge number of things out there that can cause can trigger a flare in a particular patient with already damaged or a poor skin barrier. These can range from irritants such as wool, synthetic clothing, soaps, detergents, etc., or other chemicals. It can be extremes of temperature, extremes of humidity, environmental factors, especially tobacco smoke and traffic, but also there's a strong component of colonization and infection, be it bacterial, fungal, or viral. We see a trend of concurrent illness, stress, immunization causing a worsening of skin. And then we come to allergens. Allergens are an important trigger for eczema flares, although they are not as common as the irritant triggers. So the allergens that we encounter most frequently would be the ones via direct contact with the skin, such as preservatives and skincare products or perfumes. And then there are patients who are sensitized to environmental allergens such as dust mite, animal dander, pollen, and molds. And there is a smaller number of patients who are also sensitized to food, and this is often seen in younger age groups. So when should we think about allergens, whether food or environmental allergens? So for a food allergy triggered eczema, the onset is much, much earlier, under 6 months of age. And it does not tend to exist on its own. It also causes disruption in the gastrointestinal health of the patient. So they have constipation, diarrhea, reflux, faltering growth. And they also have a temporal correlation, which can be a little bit difficult to unpick because it is in a delayed manner. But if you find that a patient strongly feels that they have a worsening of eczema with a particular food, for example, milk, then an exclusion of the food for 4 to 6 weeks should cause a significant resolution of their symptoms. And if you cannot see a significant resolution, then it's unlikely to be the food. So there is a temporal correlation. In terms of aeroallergens or environmental allergens, this is the eczema that starts or worsens later in life. There can be seasonal flares if the trigger is pollen, and there will be an improvement with a change in environment. It often involves the facial or hand eczema, and these patients can also have associated atopic airway disease. And we'll talk about a few cases that will give you a little bit of flavor for this. So when we want to manage eczema, what is it that we hope to do? We hope to reduce the symptoms, we hope to reduce and prevent the flares and reduce the chronicity. We hope to prolong symptom-free intervals and prevent infection and further sensitization. But above all, we hope to improve the quality of life both for the patient and for their family. We do have the NICE guidance for the management of atopic eczema under 12s. And the main pillars that are formulating the management steps within this guidance are firstly, having a holistic assessment of severity and impact on quality of life at each visit. It mentions emollients as being the mainstay of management, even when the skin appears clear, and then observing a stepped approach with topical treatments so that the potency of the topical corticosteroid is equivalent to the severity, where we gain rapid control and step. The use of calcineurin inhibitors is an important part of the management of eczema. What I think is perhaps most important is education for the family so that they understand that eczema is a chronic condition. It is not an overnight magical cure. Adherence and appropriate use of treatment must be followed, and also to look at any psychosocial issues. And then we should have a clear idea of any triggers that might be causing problems and how to avoid them, and also to understand when to refer to dermatology. And we will cover all of these. Just quickly to mention the severity scores for eczema. These are useful because they give us a very objective idea of how difficult the eczema is for the patient, both in terms of qualitative as well as quantitative measurements. And there is a number of scores, and each unit might choose to use something different. But once we have done the global assessment, then we look at individual areas of the skin to see whether there is mild, moderate, or severe involvement. And within the skin of the same patient, you can have different areas that have different severity and require, therefore, different treatment. Treatment with emollients is but alongside that, depending upon the area of involvement, we can use topical anti-inflammatory treatment. So face, neck, axilla, and groin, these are the areas where the skin is delicate and thin. Therefore, we use mild topical corticosteroids if the severity of eczema is mild, and we can step up to calcineurin inhibitors if the severity is moderate or more severe. We do not tend to use more potent steroids for these areas. Alongside this, at this step as well, we must think of adherence, appropriate use of treatment, infections, any other triggers or psychosocial issues. For the limbs and the trunk, the skin in these areas is thicker and more strong, and we can use slightly stronger topical corticosteroids as well. So we start again with assessment of the area and then use the topical corticosteroid that appears to be most effective. For example, if it's a severe involvement where there's a significant amount of excoriation and even underlying lichenification suggesting some chronicity, then it's better to use a potent topical corticosteroid to rapidly gain control and then step down according to the ladder. So let's start with some cases then. So we'll start with case A. This is a 5-month-old baby who has had itchy red skin since birth. The family have been using baby lotions and baby bath products, which they have obtained from the supermarket. So the first thing to understand is what is the severity of this, having a holistic approach to this patient. And when you do that in clinic, looking at this baby's skin, you're very likely to come to the conclusion that this patient has moderate eczema, where they have, which appears to be frequent involvement with areas of excoriation. So management for this baby would be starting with daily emollients. Having products from the supermarket is unlikely to be beneficial, plus they are lotions which are likely to be very thin, and also they will very likely contain preservatives and fragrances. Therefore, switching to a treatment that you can provide would be useful. And we will also need topical corticosteroids alongside giving the parent the right education. So emollients, as I have said before, are the mainstay of management. These are to be applied all the time, even when the skin looks clear, because they help strengthen the skin. Remember, we have discussed that the skin barrier in patients with eczema is weak, so we need to strengthen it. We must offer a choice of products. While they should all be of a certain pH and free of detergent and topical sensitizers, we find often that different products suit different skin types. So it's very difficult to predict what product will suit which patient. It's better to give them a choice of a few to try, and then they come back to us and tell us which they prefer. It's also important, especially for babies, that a skin care product should not contain a food allergen unless it's already ingested. So creams that contain oat, soya, or arachis, which is peanut oil, should not be used unless this is already a part of the baby's diet. This is because they might get sensitized through the broken skin barrier and actually develop an allergy to that particular food. Once we prescribe emollients, we ensure that the family know to use these liberally, at least every nappy change for infants, or at least 2 to 4 times for older children. And the only way to ensure they use them liberally is to give them an adequate supply. A number of units have emollient ladders, and this is one from Greater Manchester area, which talk about how greasy the emollients become. So if the patient's skin is broken or the barrier appears particularly weak, then it's better to give a fairly greasy emollient. The light emollients or the lotions are very unlikely to be beneficial, with the exception of Dermol, which is an antiseptic one as well, and there are other similar products. Within these emollients, the important points to remember are for the family to wash hands with soap and water before applying so that they do not introduce any infection. And similarly, pump dispensers are preferred because dipping fingers into a tub of any cream is very likely to get the whole tub infected. Therefore, if there was a cream in a tub, then it's better to use a clean spoon or a spatula to take it out. And we also advise to smooth down in the direction of hair growth so as to prevent irritation and folliculitis. Bathing, and often families ask us in clinic whether they should avoid bathing because there is a conception that frequent bathing will further erode the skin barrier and make the skin more dry. However, once daily bathing is actually recommended because a lot of these patients, as I've mentioned earlier, have an overgrowth or a colonization of bacteria, and there is a lot of crust if there's excoriation. So once daily bathing will help remove the crust, reduce the bacterial count. But the way to do it is to have a 10-minute soak so that the water itself becomes a moisturizer and goes into the skin. And then instead of rubbing, better to pat dry. Double creaming at bath time is a useful method of cleaning as well, where an emollient is applied immediately before, and then the patient has a 10-minute soak. They come out of the bath, they are patted dry, and then have another layer of emollient. So the bathing is used as another moisturizing event. If families would like to see videos, and these can be really useful, there are some available on the Itchy Sneezy Wheezy website, and they go through different topical applications as well as bathing routines. And then coming to topical steroids, and we again have steroid ladders in a step up, step down approach. So these are best to be used at the start of a flare. It's not useful to delay using them. There have been a large number of studies with regards to the side effects and risks of using steroids, and these are actually all licensed for intermittent use. There is a risk of skin atrophy, striae, and telangiectasia. However, this is on a very long-term use. NICE recommends that the potent steroids, so the top two, should not be used for over 2 weeks. They can be, however, used in short-term flares. The mild to moderate potency steroids, which is the bottom two, a lot of trials have looked at about 12 to 20 weeks of daily application, and they haven't really found much of a risk with a supervised application, where it means that there is a physician who's guiding the application and is able to guide the quantities and so on. So generally speaking, under a physician guidance, use of these steroids is considered safe. Once the families are in the clinic and we have given them the information, a lot of that information is unlikely to be retained. So therefore, a written plan is extremely useful. So similar to what we use for our asthma patients, a written eczema plan can be devised. And this is one that has been devised by University of Bristol, which I quite like. So it has the picture on the left shows the step ups and step downs that we can advise the patients, and we can write down the products that we have prescribed for them. And the picture on the right shows a few tips for the families to look through. So all in all, it's an educational as well as a ready reckoner plan. So coming back to our patient, he has improved following our management advice of emollients and topical steroids. In his case, we gave him the mild potency steroids, such as hydrocortisone 1%, and he improved. However, parents ask you that he has been developing a perioral rash, so a rash around his mouth, especially when he eats tomatoes and fruits such as strawberries, although he loves eating these. A point to make at this stage is to tell the family that this is a contact irritation. It is not an allergy. Baby's skin is extremely sensitive. especially a baby who has eczema, and it is easily irritated by various citrus and highly acidic fruits and vegetables. So the way to go about this is to use an emollient barrier. So any thick cream or ointment would do, or even Vaseline, around the baby's mouth when they're eating. If possible, avoiding contact of the food with the skin would be useful where the baby can eat with a spoon. However, that is sometimes impractical. So using a barrier and washing the face afterwards will suffice. If the baby enjoys these foods, they should not be taken out of the diet. So staying with KSA for a little bit longer. This baby improved with all our management regime and is now eating all the foods that we've advised them to. But now at the age of 1, he has returned with a recent worsening and oozing of his skin. In clinic, you would see possibly either of these two patterns. And these are important patterns to identify as well as differentiate, because this is what we need to be mindful of, the infections in eczema. It's important to understand them and alert the family to them. This is when the eczema worsens, becomes resistant to treatment, and lesions become widespread. They cause crusting, oozing, and the patient can also sometimes be systemically unwell. So the picture to the left is more suggestive of eczema herpeticum, which is a viral infection causing fever, clusters of these itchy blisters or punched out lesions, and a severe infection can be very, very dangerous and can even be fatal. It requires urgent treatment with systemic acyclovir, and any topical anti-inflammatory treatments such as steroids and calcineurin inhibitors must be stopped. The picture on the right is a little bit more suggestive of staphylococcus because there is crusting, the yellowish kind of ooze that is coming through these lesions. There's excoriations and pustules. These patients can often have a local lymph node enlargement, such as cervical lymph node enlargement, and they also require immediate treatment with systemic antibiotics. So this brings us to the next step in the management, where it's important to educate the families to look out for infection and to be able to come to a healthcare setting once an identification has been spotted. Let's look at another case now, case B. This is an 8-year-old who has had eczema from the age of 2 years, and this has worsened recently. There are no dietary restrictions or known allergies. The worst affected areas are face and hands. The family have recently moved house, and the child sleeps in a bottom bunk bed, and his eczema was so much better when they were away on a holiday, which is quite a common pattern. On your assessment, you spot that he has these areas of dry, lichenified skin with excoriations, and it involves a fair amount of skin, therefore it is moderate eczema. This is when we consider the external irritant or environmental allergen, because this patient had a late onset eczema, and the areas affected are more exposed areas such as face, especially eyelids, neck and hands. And we've got our hint when the patient's eczema has improved when they went away and worsened when they went into a new home, which probably is more carpeted. So the common trigger in this case, I would consider house dust mite or pet, but if he had seasonal flares, then pollen should be considered as well. So this is when we think about the trigger identification, whether it's allergen, irritant, or infection, and give the family appropriate avoidance advice. Case C is another patient, 3-year-old, whose eczema has started since infancy, and this patient is itchy all the time, so they have disturbed sleep. On examination, you feel that the skin is actually fairly clear, but the parents describe constant itching despite using emollients and all the skincare regime that you have suggested. So they have asked for chlorphenamine, which is a sedating antihistamine, because they feel that's the only thing that helps. This is where I want to emphasize that eczema is what we call the itch that rashes. It's a chronic itch. It's complex and it's not always driven by histamine. There is, in fact, a number of studies that suggest that the whole skin becomes oversensitive. So there's hyperinnervation of skin with increased itch mediators. So sedating antihistamines work only through sedation. So when we give this patient chlorphenamine, we are effectively giving them a sedative to fall asleep, but they do not directly help with the pruritus. The best treatment for these patients is to tackle what is probably an underlying inflammation. So topical corticosteroids and calcineurin inhibitors to relieve the inflammation from the lower layers of skin is really important. And then some of our patients would have more of a habitual itching. Therefore, we need a little bit of counseling and habit reversal techniques. It's also important for this patient to consider hypersensitivity to the medications we are providing. So certain creams have preservatives and fragrances which can cause contact dermatitis. Could this patient be using a skincare product that's causing the itching? One of the ways to find out is to stop all the treatments that are being used and do an open application test, where we choose a relatively clear area of skin, apply the product in question twice a day for a week, and then see how that area compares with the rest of the skin. And the same thing can be done with sun protection creams, which are another concern for families with eczema. And this brings us to our next case, case D, which is a 12-year-old young person who's had severe eczema starting in infancy but getting worse. He has been using moderate potency topical steroids for the last 6 months, almost continuously, so that the skin improves when these are used, but then relapses quite quickly when they are stopped. On examination, you can see widespread excoriation, lichenified, hyperpigmented skin, and there is obviously a significant impact on quality of life. So this is severe eczema, and this patient is dependent on topical steroids. So how do we reduce steroid dependence, which is a big problem for patients with eczema? There are a number of ways to do this. First of all, when we use steroids, we should use them appropriately. So the right potency and the right amount rather than using a small amount or lower potency. For example, for an area of skin that has moderate eczema flare, using a mild steroid will not really help, and the family might end up using it for longer. And then weaning rather than abruptly stopping topical treatment is important, and then stepping down to either lower potency or alternate day or both. And some patients require weekend therapy. Here's a diagram that explains what weekend therapy means. It is more of a proactive rather than reactive treatment. So the reactive management on the left treats whenever the patient has a flare so that they tackle some of the subclinical inflammation, but some of it remains. Whereas the proactive management is a method of down-regulating the inflammation in the subclinical areas so that the lower layers of skin are also tackled by the So these can be done with the means of medium and high potency topical steroids to use flares, and then moving down to a lower potency on a twice weekly or an alternate day calcineurin inhibitors as a maintenance for patients who are prone to frequent relapses. And these can help with improving the subclinical inflammation. The other way of reducing steroid dependence is to step down to calcineurin inhibitors. So calcineurin inhibitors are recommended as a second line for patients requiring ongoing daily topical steroids, which means over 4 to 6 weeks for face and over 4 months for body. And the potency wise, we've got tacrolimus, which is the strongest, 0.1%, then tacrolimus 0.03, and then we have pimecrolimus or Elidel. These help repair the skin barrier alongside reducing the inflammation. And the way to use it is quite similar to topical steroids. So fingertip unit is important, and sun protection is also important as a guide for these patients. There are various ways of using them. One of the regimes that can be followed is start by treating with a steroid for a week, and then using steroid in the morning, tacrolimus or another topical called calcineurin inhibitor in the evening, then switching to calcineurin inhibitor both in the morning and evening for another 2 to 4 weeks, and then just once daily application for 4 to 12 weeks, and then alternate day or a weekend therapy if so needed. And then that brings us to our final pillar of management of eczema in primary and secondary care, which is referral to dermatology. So who needs to be referred to dermatology? This is when we have diagnostic uncertainty, so skin conditions that look like eczema but perhaps aren't, or there is severe eczema, or moderate to severe eczema which is only partially responding to our topical steroids or topical calcineurin inhibitors, or there is a concern with regards to the amount of steroid use and the side effects of that, or there is possibly contact allergic dermatitis where a patch test might be useful, or simply we feel that we have offered all we could and we need more help. And dermatology could thereafter offer further treatments. So Wet wraps and bandages can be done by either the secondary care colleagues or dermatology, and then they can also offer phototherapy, systemic immunosuppressants, and biologics, which are quite the game changer in eczema management. And these include dupilumab, which is the monoclonal antibody against interleukin 4 receptor alpha and inhibits both interleukin 4 and 13 signaling, and the tralokinumab, which neutralizes anti-interleukin 13. And we have seen a significant benefit from both of these. So my take-home points are eczema is a skin barrier defect. There's a wide range of triggers, most of which are environmental. It's important to get the management right by initiating emollients, using them regularly in generous amounts, and educating the family with recognition and the appropriate escalation of treatment for flares. It's important to step up and step down with topical steroids, and also really important to ensure holistic assessment and education for the patient as well as their families. Thank you very much for your attention.
Thank you so much, Dr. Grewal, for such an interesting and engaging presentation. I'm sure those watching will agree it set the scene really nicely for laying the foundations to understand a little bit more about eczema. I think the case studies just brought this to life really well. Our next session, we're privileged to be joined by one of the country's leading experts in paediatric dermatology, Professor Carsten Flohr, who's here to talk about the link between eczema and food allergies, which is so important and so relevant to our work in clinical practice. So without any further delay, I'd like to welcome Professor Carsten.
Hello, I'm Carsten Flohr. I'm Professor of Dermatology and Population Health Science at St John's Institute of Dermatology, King's College London, and I'm grateful to have been asked to talk about the link between eczema and food allergies, something very close to my heart and research interests. So I'm going to take you to one of my patients to illustrate the links that we're seeing between eczema and food allergies. We'll talk a little bit about allergy tests and how you interpret them in the eczema context. And then we'll also talk about the role of the skin barrier in the development of food allergy. So I met this girl when she was 9 months old. She had eczema since age 2 months, had significant sleep disturbance. Her GP had prescribed moisturizers and 1% hydrocortisone ointment, with the parents reporting that that really didn't make much of a difference. She was still being breastfed at night and started formula milk 3 months earlier. And at that stage, it seemed that the eczema got worse. She was also avoiding egg because of a family history of egg allergy. So in your practice, you would then examine the patient. Of course, you can see typical mild to moderate severity eczema there over the extensor surfaces of the arm, the legs, but also the typical flexural involvement there behind the knees as well. No obvious skin infection, which is good, but some scratch marks there in the left popliteal fossa. So how would I manage this child? Well, I suggest that you optimize her eczema treatment first and then think about the food allergy. And that is not to say you're belittling the parents' concerns about food allergy. Clearly, if a sibling has got already an egg allergy, that's going to be at the front of their mind. They're wondering whether that is going to be one of the main reasons for the eczema, but it's still better to do it this way. And if you work in general practice, you won't have that much time anyway to wrap it all up in one anyway. So concentrate on eczema treatment first. So you prescribe some Humavate for her. So that's moderate potency topical steroid, and rather than 1% hydrocortisone in the eczema is much better controlled, and that's great. And you can now think about this issue around formula milk starting 3 months ago and the eczema getting worse at that stage, and then the avoidance of egg as well. Question to you as the audience: how common is food allergy in children with eczema at the population level? Is it A, over 50%, B, around 30%, or C, below 20%? And the emphasis here is at the population level. So if you're going to go out into a school setting, for instance, somewhere, and use double-blind placebo-controlled food challenges as the way of diagnosing food allergy, so the gold standard. How common is food allergy in children with eczema? Well, it is below 20%, but that's still higher than certainly I would have expected. The data comes from a variety of studies. Hospital cohorts have got a much higher prevalence of food allergy amongst eczema patients, well over 60%, but at the population level, it's around 15%. That data mainly comes from Denmark, where colleagues took a true population-based sample and did food challenges in those where there was a suspicion of food allergy. Our team asked the very question around whether atopic dermatitis, or eczema, just as the term, causes food allergy a number of years ago in the context of a systematic review. And we did come to the conclusion that there seemed to be a causal link in a lot of patients, partly because food allergy and eczema have that association there at the hospital and population-based level. But at the same time, if you go into the community, then the levels are not as strong as some have suggested previously. This is a very simplistic view, of course, just looking at how common is food allergy cross-sectionally in children in the community with eczema. And age of onset and actually eczema severity are very important additional factors in this equation. So this is work by David Hill and other colleagues, a substantial sample of over 2,000 participants from 94 centers, 12 countries, all children with early onset eczema, and looking at their disease severity with the SCORAD index, which is a very common eczema severity score, as well as taking blood for specific IgE to milk, egg, and peanut, arguably the three foods most important in the eczema context, and using published 95% positive predictive values to decide whether these children were likely to be clinically allergic or not. What we're seeing here is from Q1 to Q4 is the eczema severity and the percentage of food allergy based on the specific IgE levels and the 95% positive predictive values. You see that stepwise increase in the likelihood of food allergy with an increase in disease severity in those where the eczema started under 3 months of age. Very similar stepwise increase all the way up to 12 months when that really leveled off. So the take-home message from that is it is worth looking for food allergy in infants with moderate to severe eczema. Coming back to our patient. So she started formula milk 3 months ago and the eczema got worse. What do you want to ask the parents next in your consultation? Well, you'd want to ask about typical symptoms of IgE-mediated food allergy, don't you? And you want to know the time window of those. So we're talking about hives, urticaria, angioedema, so soft tissue swelling, for instance, around the mouth or the eyes, wheezing, GI symptoms such as vomiting and diarrhea, and in severe cases, anaphylaxis. But the window is usually within 2 hours for immediate type reactions to foods. They're easy to diagnose because we've got validated tests, skin prick testing, abbreviated here SPT, and specific IgE testing, and clear positive predictive values that have been published to decide whether someone is likely to be allergic to a food or not. The mechanisms are clear, and we've got the gold standard test of a double-blind placebo-controlled food challenge. I'd like to show you a video of a child kindly shared by the parents who was known to be milk allergic. The parents live in Australia in the remote area, so they decided to test at home whether the child was still allergic, not something I would recommend you do. And you can see how the skin becomes erythematous, where eczema was previously. You can see the difficulty breathing, the swelling of the mouth area. Clearly, this child is still allergic to milk. "90% of all IgE-mediated food allergies and eczema are caused by 6 foods. They're listed here. milk, egg, peanuts, codfish, soya, and wheat. That's worthwhile as a list, keeping in mind when you approach children with eczema where you're thinking of an IgE-mediated food allergy. Now, there was this history of eczema worsening when formula was introduced, but when you ask your questions, the parents deny any immediate type symptoms. And you do skin prick testing, if you had that available, or you could do skin-specific IgE testing in your practice, and it's negative for cow's milk. Question to you, does this rule out cow's milk protein allergy in this child with eczema? Well, the answer is not necessarily, because there are non-IgE mediated food allergies as well, so-called delayed hypersensitivity to foods. Delayed meaning well beyond the 2-hour window, usually 24 hours later, presenting with eczema or reflux or sometimes diarrhea, vomiting, abdominal pain. This is much more difficult to diagnose. The mechanisms are still unclear. We don't have validated tests. So essentially, you have to resort to an exclusion diet, hoping that that then shows that the eczema gets better and then reintroduce. What do the NICE guidelines for eczema say? Well, you should trial 6 to 8 weeks of an extensively hydrolyzed protein formula, amino acid-based formula in place of cow's milk formula for bottle-fed infants aged under 6 months with moderate or severe atopic eczema that has not been controlled by optimal treatment with emollients and with mild topical corticosteroids. So it's about optimizing of topical therapy first. If the eczema doesn't respond, and there seems to be a link in the history between cow's milk formula introduction, for instance, the eczema flaring, or in other forms, cow's milk protein exposure and eczema flaring, then it's worthwhile going for that trial of exclusion. A few words about the hydrolysis of cow's milk protein as part of the preparation and manufacturing of milks. So obviously fresh cow's milk has got intact protein. Some products are partially hydrolyzed. I mean, they're not worthwhile going for when you're thinking about a child with cow's milk mediated delayed type hypersensitivity. But extensively hydrolyzed formula has peptides that at 95% level are under 1,000 Daltons, so should not be recognized by the human immune system. Only amino acid-based formula, however, is completely broken down. So there's no potential for allergenicity, but it tastes vile. It's very hard to introduce that to a baby that is used to breastfeeding, for instance. The extensively hydrolyzed formulas are much more palatable. Soya formulas, and just this is very briefly about the sort of more specialized formulations that are available. Soya formulas should not be used under 6 months. And there's a big price difference, as you can see here, between the extensively hydrolyzed ones and the amino acid-based ones, which are much more pricey. Something else to keep in mind. So how common are delayed eczema flares in food allergy? Probably the best study, now almost 20 years ago, was done by German colleagues. They did double-blind placebo-controlled food challenges to milk, egg, wheat, and soya in children with a median age of 2 years in those with eczema and suspected food allergy. And if you go down this tree there, you see that 12% had a delayed eczematous reaction only. So as a distinct entity, delayed eczema flares due to food protein hypersensitivity are quite rare. The main foods involved here are milk, egg, soya, and wheat. So in this case, we actually didn't go down the route of the exclusion diet, and the reason being was that the eczema responded very well to the use of Humavate. So very unlikely that the cow's milk protein, which we didn't remove from the diet at that stage, had anything to do with with the eczema, and that's really helpful again then to break up the consultation into addressing eczema management first and then looking at potential food allergies second. So what about this history of avoiding egg because of a family history of egg allergy? It's tricky, isn't it? Because you don't have a history of exposure. So we did skin prick testing in your practice as primary care physicians. You could do specific IgE testing to egg solution and raw egg. We did here skin prick testings. Egg solution is less sensitive than raw egg. You can see the differences there in diameter, but with those skin prick test diameter reactions, very likely that this child is clinically allergic, even in the absence of having had exposure previously. So we recommended avoidance and referred to a pediatric allergy clinician and pediatric dietitian for their input there. More important maybe, and that has also some other consequences in terms of what you might want to take home from this talk in primary care. How did this child become allergic to eggs, do you think? And that brings us back to our systematic review from 2016 that I alluded to earlier, where we looked at that association between eczema and food allergies at the population and hospital levels. You remember me talking about the higher levels seen in hospital cohorts, which have more severe disease compared to population-based settings. And that systematic review also found evidence that by and large, eczema precedes food allergy. So in that systematic review, we did indeed come to that conclusion that eczema is the portal or the gateway, if you like, to food allergy. And once you're allergic and then exposed to the food, let's say egg, then that can worsen the eczema and flare the disease. And the mechanism that is proposed for this is transcutaneous sensitization, with the inflamed skin as the portal entry for the food protein. Well, but let's start at the beginning of this story. So does regular emollient application prevent eczema? And I'll come back to the food allergy in a moment. We thought we were onto a winner. Back in 2014, two pilot randomized controlled trials were published, one from Japan, the other one was a joint effort from colleagues in the UK, as well as the US. And both studies, with just over 100 participants, suggested an up to 50% reduction in the risk of eczema during the first year of life in high-risk infants, high risk referring to a family history of atopy, so asthma, hay fever, or eczema. So using emollients from day one after birth seems an effective, safe, and cheap way of preventing eczema. That was then the argument for the NHR Health Technology Assessment Board to fund the Barrier Enhancement Eczema Prevention Trial, BEEP, which recruited almost 1,400 newborn infants at high risk to either regular emollient application from birth or standard care. And there was a choice between dipro-based cream and double-base, which was based on previous feasibility work with parents. But when we are actually, as a trial team, and I was involved in the study as a principal investigator at Guy's and St Thomas's Hospital, when we sat in the reveal meeting with the investigators, our heads were drooping when we saw the results. You'd be familiar with forest plots, no doubt, but just to talk you through this forest plot step by step. So this dotted line here, one is the line of no association. And you can see that the estimate overall for the BEEP trial intervention, intensive emollients therapy from day one after birth versus standard care, sits literally on the line of no association. And then we try to look at the data in all sorts of directions, from all sorts of angles, whether people had a water softener or not, what the season of birth was, whether children had a filaggrin loss of function skin barrier gene mutation, whether there's a first degree relative history with eczema, yes or no, and so on and so on. But no matter how we tried to slice the cake, there was really no statistically significant association seen. And this is for the relative risk of atopic eczema by 2 years of age. In the same issue of The Lancet in 2021, the Prevent et al. Trial team from Sweden and Norway published their trial, which is a factorial multicenter cluster randomized trial that has a food allergy prevention component, but also an allergy prevention arm. Again, no effect. So we can conclude from this work that emollients do not help to prevent eczema. But the story becomes even more interesting, because we had anticipated that there may be a link between eczema and food allergy through transcutaneous sensitization. We looked at food allergy as an important outcome as well, and this is challenge proven food allergy, milk, egg, or peanut by 2 years in the BEEP trial in the intervention compared to the control arm. Well, we thought we were preventing food allergy if we're preventing atopic eczema. As you just heard, we didn't prevent the eczema. And looking at this year with the estimate, the adjusted relative risk sitting 1.5, so 50% increase in risk of food allergy at 2 years. Even if the confidence interval is just crossing 1, it is almost statistically significant, and that was very interesting. To a degree, a big surprise. What's going on here? I've already mentioned transcutaneous sensitization to foods potentially being important in this story, linking eczema with food allergy. So the question that we asked was, does the regular contact of the parents' hands with their children's skin through the moisturization on a daily basis facilitate the transcutaneous sensitization to these foods? We had another data set, the Inquiring About Tolerance trial that I was involved in co-leading with our pediatric allergy team at Guy's and St. Thomas's a number of years ago, where we have very careful skin examination findings for 3 months, 1 year, and 36 months. We have information on moisturization frequency and skincare, as well as transepidermal water loss, which is a measure of skin barrier integrity, food sensitization, as well as challenge-proven food allergy data from the 1 year and the 36 months follow-up points. So we're looking at this question in the EAT trial, the association of the frequency of moisturizer use in early infancy and how that links in with the potential development of food allergy until 3 years of age. And you can see here on the right-hand side, we're looking at the moisturization frequency from never to once a week, 2 to 4 times a week, 5 to 6 times a week, daily or more than daily, and the percentage of those developing challenge-proven food allergy. There's quite a dramatic increase if you apply your moisturizer more than daily. And interesting, that was in infants with or without visible eczema. So it really seems that regular moisturization of the skin of young infants can promote the development of food allergy, most likely through transcutaneous sensitization. And I'm now leading an EU-funded project called Transfoods, where we're trying to drill down further into the mechanisms of how that happens. We think it's the opening up of the hair follicles through the massaging movements of the parent's hands and the contamination of the parent's skin, leading to food proteins such as peanut protein getting trapped in hair follicles, and through that making contact with the child's immune system. It would be really helpful finding out how it really happens and if what we are hypothesizing is true. But until then, when we might be able to develop novel methods of food allergy prevention based on those findings, I would advocate meticulous hand hygiene before moisturizer application and baby massage, and also to avoid food protein containing emollients in children with eczema. So this brings me to the end. Just to recap what I've talked about. So I started with a case scenario, talked about the links between eczema and food allergy at the population level. I talked you through the allergy tests and the interpretation in the context of this child's case. We talked at the end about the role of the skin barrier in food allergy, and that regular moisturizer use from early life does not prevent eczema or food allergy, and that there is that risk of transcutaneous sensitization, so meticulous hand hygiene is important. Thank you very much.
Thank you very much to Professor Carsten Flohr for such an eloquent explanation of the link between eczema and food allergies. We're going to take a break now, and we will resume the third presentation of the morning at 11 a.m. Thank you to those who have connected with us already on Slido with your questions. We have quite a few, but we would encourage you to connect with us and ask some more questions. We've got a real expert panel waiting for your questions, and we've got a real golden opportunity to get those answered. So if you have time during the comfort break, then please do get some questions across to us, and we will resume again at 11 a.m. for the third and final session of the morning. Thank you. and I'm delighted to introduce my next speaker, who is here to discuss the management of eczema. So welcome, Odette, and thank you.
Thank you, Holly, for inviting me to do this talk today. I'm delighted to be here to talk to you about eczema management. So the things I'm going to cover today are the practical management of eczema, so that we get a good understanding of how to treat mild to moderate eczema, just some little bit of information about how to treat severe eczema, trigger avoidance, prevention of infection and what to do if eczema becomes infected, the red flags and when to refer to secondary care, and some take-home messages. So our goal for eczema is always the aim for improvement. We want to support and guide the children and families that we look after, and in doing that, restore the skin barrier function for them by using regular moisturizers or emollients, soap substitutes, and bath emollients where appropriate. So complete emollient therapy is definitely the way to get eczema as well controlled as is possible. So eczema skin is naturally very dry. Our aim is to prevent itch, to protect the skin barrier, and to improve the dryness. By doing all of those, what we'll be helping to is to control the itch scratch cycle. So some practical ideas here about bathing, because there are lots of different schools of thought about how often to bath and how to bath. But by bathing, we're helping to maintain a healthy skin barrier function. So regular baths in warm water, ideally for 5 to 10 minutes, but no longer than 20 minutes. Although bath additives are not routinely prescribed, you can use the leave-on moisturizers or soap substitutes in the bath, and a lot of the greasy moisturizers are water soluble, so you can dissolve them and add them to the bath. The regular use of non-perfumed products, so soap substitutes that are non-perfumed for washing, and gentle shampoos for washing hair. Now with children, they can become very slippery in the bath, so using a bath mat to prevent slipping can be helpful. And with bath toys, some of the squeezy bath toys that hold on to water can sometimes encourage mold growth. So having bath toys that can be washed and dried at the end of each bath can be helpful. It tends to be the squirty toys that hold the bath water. So remembering to change towels and sponges regularly, not leaving sponges damp, letting them dry out naturally at the end of the bath, and remembering to pat dry with a nice soft towel at the end of your bath rather than rubbing, which can encourage irritation. So if you're giving this information to families, just give them some tips and hints on how to do it, because people do get very worried about bathing. Many people don't want to bath, particularly children, very often. But bathing does increase the uptake of moisturizer, and it takes off all the old creams and reduces the risk of infection. So it has some really good benefits. There's lots of information out and about now about bleach or antiseptic baths. It's a bit like swimming. So you need to soak in chlorinated water for about 10 minutes. We generally use Milton diluted in bath water. For a young child or baby, they use about a quarter of an adult size bath. So that would be about 1 capful of Milton to ensure that it is really well diluted. It's important to discuss with the family how to use this, or to the patient that you're asking to use the bleach baths, because it brings quite a lot of fear, but it can be good, potentially very good for those with repeated infections, but cannot often be quite soothing. So sometimes worth a try with families. So we're going to have look now at some of the guidelines that are available, and these are from the National Institute for Clinical Excellence. They were published in 2021, and it is about a stepped care plan. So for mild to moderate eczema, we're looking at mild potency topical steroids with some moisturizers, which we'll explore a little more in a while. And then going up to the more moderate atopic eczema, that's where you can add in things like the bandages and garments, and then some topical calcineurin inhibitors. When you're getting to the severe level of atopic eczema, this is generally managed in a secondary care setting, where you would have access to things like the phototherapy and systemic therapies, and adding on to that biologic therapies now. So treatment options for mild to moderate eczema. The mainstay of treatment is always going to be the emollients or moisturizers, but adding in some mild to moderate topical steroids, and when you're getting to the moderate, the calcineurin inhibitors, the bandages, garments and gloves. So with emollients, eczema is prone to dryness, so you need to be using moisturizers regularly. We all know with eczema, the key characteristic is itch, and itch can lead to lots of problems, in particular, sleep deprivation, frustration, stress, increased risk of infection. It gives you much more thickened skin, which gives you less flexibility and more need for moisturizer use. But we all know that itch is intense. So children and adults with eczema will report that the urge to itch is absolutely desperate sometimes. So we've got to acknowledge that itch scratch exists, and we need to acknowledge when it's with a child that it will affect the whole family. So using moisturizers absolutely every day, a good quality moisturizer will reduce the itch and scratch and will ultimately reduce the dry skin. The NICE guidance suggests 250 grams to 500 grams of moisturizer a week. And it's really helpful if you're working with families to show them a 500 gram tub of moisturizer, because this will help them to visualize how much they actually need to use. The focus in eczema management in some situations is often around the topical steroids, but if we can flip that and make it all about the moisturizers, the families will use more. But my experience of working with children with eczema and adolescents and young adults is that there's much more underuse than there is overuse. So really, by helping them to visualize and giving them options about moisturizers will help to gain that compliance and concordance with their treatment, and hopefully ultimately improve their skin. Ointments can be more effective than creams, but they are often very greasy. For some, they're not very user-friendly. So it is really about encouraging the use and having options. So there are lots of different types of moisturizers. I've given you here a list of some of the ones that are available. Starting at the bottom, there are the lotions with antimicrobials, such as the Dermal 500, which is often used as a soap substitute. It's a very light lotion, so sometimes not very moisturizing. Then you've got things like the gels. These are, again, very light. They would need to be used very often and sometimes are not very effective with very young children. The creams with urea are very good for softening thickened skin, but again, not really very used in very young children, but can be helpful, particularly in toddlers and above. And then you've got the creams, which are your everyday. So moisturizing creams are the things that are very user-friendly, can be used every day and should be used in large amounts. There are various creams of different thicknesses, so it is really finding the cream which is going to work is the cream that's going to be used regularly. So encouraging your child or adolescent or adult to choose a cream that they like using, because if they like using it, they'll use it lots. And then some of the more effective creams can be your greasier and very greasy options. So all of the greasy options can be dissolved and added to baths. They can also be used as soap substitutes as well as moisturizers. And the very greasy, so things like the 50-50, that's one that's used very frequently in the hospital situation, particularly where people have got very, very painful skin, because it's easy to apply. It just smooths on, doesn't require any rubbing, quickly applied, can be used out of the fridge, so it can be used very cold if people prefer their creams very cold, but generally very, very well tolerated. So how are they used and when are they used? So teaching the people that we work with that they need to wash their hands before applying, particularly if you're working with very young children. You want to make sure that the hands are free from any potential irritants, so particularly foods or chemicals that may cause extra irritation. Emollients should be applied liberally and frequently, and especially after bathing for extra hydration. So some people will require to use their creams much more frequently than others, but it is really important to apply it gently, to slide in the direction of hair growth, and I usually suggest starting at the top and working downwards because you follow the lines of the hair. Never to rub up and down vigorously because this can irritate the hair follicles and cause a condition called folliculitis, but it can also cause heat and irritation. So we want to just let it soak in naturally, letting the excess soak in on its own without any help. Remembering that if you're using the greasier moisturizers, you do need to have a spoon or a spatula to take it out with so that you're not encouraging bacteria growth in the pots. We also want to make sure that anybody that's using moisturizer is not extra hot during the application. So again, the creams can be used out of the fridge if needed. And we often find with the families that we work with that they will reduce the amount of moisturizer during the summer months because their skin is much better, or they don't need to use it so frequently because they're applying things like sunscreen, or they're away on holiday and the skin is much improved. But once the weather changes in the autumn, it's really important to highlight that actually the skin becomes much drier and they may need to increase the amount of moisturizer that they're using. So continuing to use emollients even when the skin is really, really well controlled will help to prevent flare-ups from happening. So on to anti-inflammatory treatments. So these are your topical corticosteroids. They come in both creams and ointments, and they come in different classes. There is much fear about topical steroid use, and if you're using this with families or adults that you're working with, then please do ask to have a look at their tubes of ointment or cream, because often there's very little used out of it, even though they've been told potentially how to use it. It's really important to use these proactively rather than reactively, because over the time of the flare, you will actually use much, much less topical steroid. And this can be reassuring for people that you're working with. Our aim with anti-inflammatory treatments is to return the skin barrier to some kind of normality and to treat and gain trust, because if we can gain the trust of the people we're working with, then often you'll find that compliance and concordance is much better. So the steroid ladder, which I know you've been through already this morning, it's important to use the right strength of topical steroid for the right place. So for areas on the face, you might want to use the hydrocortisone, but if you're looking at the body, then you might want to step up a level. If you've got very severe flares, you may be using the potent steroids for a short period of time. It's very unusual in children, particularly, to use the very potent, but there is a place for it, particularly with adults when needed. With topical steroids, it's really important to use them past the look good point so that we're achieving hidden healing. Because if we can do that, we gain the trust of the people that we're working with, which can ultimately affect the long-term management. So fingertip units help to give guidance to families, particularly when they're using topical steroids. So your fingertip unit is from the crease of your finger to the end. And if you actually squirt some topical steroid or some cream onto that, you'll realise how much actually needs to be applied. 1 fingertip unit is approximately 1 to 2 grams of topical steroid and should be applied appropriately to each area of the body. So a fingertip unit will cover approximately 2 of your hands. So when you're looking at the size of the child, you can then give, or adult, then you can give some guidance to how much of the topical steroid actually needs to be used. It's really good for people to visualize how much this is, because I'm sure you, like me, often get told that we're using a pea-size bit and spreading it as far as we possibly can and wondering why the eczema is not improving. Obviously, a whole body is not likely to be involved for very long, but you may well have a whole body that is needing to be treated. So having a couple of different topical steroids can sometimes be quite confusing, particularly to families with young children. So making sure that they have a written management plan so that they know exactly what they're applying, how long they're applying it for, and how to use it properly. I often advise our families to use this just once a day because they will tend to use it properly. If you tend to ask people to use something twice a day, then experience shows that they will ultimately use less. So spending some time with them, teaching them how to use it, can gain great results for everybody involved. When you've got slightly more difficult to manage eczema, we might want to step up and use the calcineurin inhibitors. These are really useful for particularly children and adolescents when they're starting to use more topical steroid more frequently. They alter the immune system by blocking one of the chemicals that contributes to flares. There are some side effects associated with them, particularly with the tacrolimus, so the protopic. We know that there may be an increase in infections, particularly the herpes simplex virus. There can be some burning and tingling, particularly warmth to the skin when this is first applied. It usually settles within 7 to 10 days, but it is about giving that information, because if the families are expecting it, then often they can negate these side effects with particularly older children who generally, if you can get them using it, it will work really very well. There should be no vaccines for 14 days if you're starting to use the tacrolimus or the pimecrolimus, and no live vaccines for 28 days. The tacrolimus in particular is off license, so we are using it off license for children, but be reassured that lots of items are used off license for children, but it is just about informing the families and letting them know. So there are many bandages and garments available in various different guises. So things like the vests and leggings, or just the Tubifast tubular bandage, which can be used to make suits if needed. There are different companies that supply these now, and they are available. They are available on prescription. Depends what's on your formulary locally to you. They are also available to buy. But very useful is the zinc impregnated bandages. These are useful for thickened eczema, particularly around hands and feet or lower legs. They come as a tubular bandage, individually wrapped, so you can cut them and use them in small areas, or you can use the whole sock. You can also get zinc impregnated bandages, which you can use to wrap round as well. To purchase, there are things like the scratch sleeves, which are cotton garments with silk mitts and socks, which are available. And there's lots of information on the National Eczema Society, who have a fact sheet, and there's also some on the Allergy UK website. So treatments for severe eczema. If you're getting to this level, it's likely that your child, young person or adult that you're working with will require referral to secondary care, because this is where we're probably using more potent topical steroids, maybe for longer periods of time, adding in things like the calcineurin inhibitors. We may be considering a course of oral steroids or a course of phototherapy, which would need to be undertaken in a dermatology unit. Or it may be that there is some consideration around starting some of the immunosuppressant treatments. Systemic treatments that are either tablet or injection and include things like the methotrexate or azathioprine, or if those don't provide the appropriate treatment plan, then it may be that you're then stepping up to biologic treatments such as dupilumab. But there are treatments available. They are developing all the time, and certainly as time is progressing, more and more are becoming available. So there are always options, but sometimes it's about treating well with the topical treatment and then stepping up and using alternatives to encourage treatment and aid treatment. So trigger avoidance is something we talk about all the time, but it is really sometimes very difficult to identify. It varies from person to person. Some triggers are very, very easily identified, and sometimes flares have absolutely no triggers. It's important to therefore maybe have a journey through those triggers and keep a symptom diary, because that may help to track which triggers are causing more problems. Once you've been able to track it and identify it and work out what aggravates the eczema, then it's easier to eliminate exposure to those. But it's often quite a tricky conversation with families to get them to start to identify symptoms. And by using a symptom diary at both either home and nursery or home and school, home and work, then sometimes you can identify different environments that are potentially causing a problem. So there's lots of triggers to consider in young children. It may be coughs and colds, viruses and teething. Again, it may be food. So common food allergies in young children with eczema, as we know, are milk, egg and peanut. Particularly during weaning, contact reactions to the histamine containing foods such as tomatoes, citrus and berries can often cause families quite a lot of uncertainty about, is this a food allergy or is it not? But if it causes a red facial reaction, particularly around the perioral area, then it's likely to be much more a contact reaction to foods that are eaten. This can sometimes be negated with the greasy moisturizers being applied to the hands, neck and face pre-food. You can sometimes see that that will reduce some of the contact reactions. The other contact reaction, which is very common in young children, is where you get a perioral eczema around the dummy. So if they're sucking on the dummy lots, you may find that that irritates with the saliva around the mouth and the chin. So other triggers which can be difficult to identify, but laundry detergents and things like water wipes in babies will often contain citric acid and can sometimes be quite irritant. Different toiletries, which are much more the chemicals. Getting too hot and sweating. So if you've got a teenager who's undertaking lots of sport and they're getting very hot and sweaty, but their eczema is flaring, it might be around that. It can be as simple as the change in weather. As children grow, they may then grow into much more of the contact allergens around the environment. So things like dust mites and animals and pollens can sometimes be triggers. So what to do if eczema becomes infected? Children's skin naturally carries bacteria, and all of our skin naturally carries bacteria. So not all skin will be infected, but it's important to recognise the oozing, weeping and crusting. Sometimes there can be increased itch, pain and warmth to the skin. The skin may become red and swollen, and the child or adult may become unwell or even have a fever. So we want to treat this early. It may be that you need increased topical steroids or antibiotic creams or liquids to be prescribed by yourselves as GPs or healthcare professionals. Not all flares, though, with weeping or crusting will respond to antibiotics. So sometimes this just needs a slightly stronger topical steroid and more topical treatments. Eczema sufferers are more prone to viral warts and molluscum, so having that information available to share with the families that you work with is often reassuring to them because there are often not very many treatments available. So in severe infections, eczema herpeticum is a secondary infection caused by the herpes simplex virus. It will affect up to 3% of all people with atopic dermatitis. They will need antiviral treatment, and in severe cases, they may need to be seen same day by dermatology, or if it's around the eyes, then dermatology departments will then refer on to ophthalmology, just to make sure there is no long-term effects to the eyes. So top tips for preventing infections. We want to make sure that everybody is washing their hands before applying creams, dotting and dabbing the moisturizers onto the skin and then smoothing them on rather than rubbing excessively can help to prevent infections. Applying moisturizers liberally and frequently and letting the excess soak in. Removing ointments or creams with a spoon or spatula and changing all pots after infections. But with young children, particularly keeping nails short to prevent the scratching damage, and washing bedding, towels and clothes regularly. So there's lots of invisible impact to eczema, particularly to parents. So often they'll tell you that other parents don't have to think about whether they bath their child too little or too often, worrying about your children scratching until they bleed, the fact that parents will often co-sleep or hold their children's hands to stop them scratching. So recognizing these and giving them support and advice to try to manage the eczema can prevent quite a lot of these things from happening. There's lots of fear about topical steroid use, so sharing that information and reassuring them that if they worry about the next flare, they can proactively treat their eczema with the topical steroids. There is lots of stress, particularly around fear of food allergies, so giving appropriate information at the time of weaning for the early introduction of some of the foods can allay a lot of the fears. So it's really just about the right information at the right time. So red flags when to refer to secondary care. If the eczema is worsening or not responding to prescribed treatments, if the eczema is becoming difficult to manage or difficult to control using the mild to moderate treatments, if there are multiple atopic conditions, so if you have a baby with lots of food allergies, difficult to manage eczema, or if you have a child with asthma and atopic eczema and it's all becoming a little bit more difficult to manage, then refer into secondary care. Or if people are having repeated infections, just to see if there is any additional support that secondary care can offer. So the take-home messages from this morning, I personally think that having the right level of knowledge and support and information about eczema is the key to treating and managing the condition. So we want timely diagnosis and support, making sure that people are using their moisturizers liberally and frequently, proactively treating flares, so using the right level of treatment for the right length of time to treat it properly, having information about itch and scratch, knowing the signs of infection, and when we need to refer, so referring at an appropriate time. Also being aware of food allergies and trigger avoidance, and giving information about moisturizers, as lots of them are paraffin based and they are all flammable, so giving safety advice to our families and adults that we're working with so that we can ensure that they remain safe. So I hope that's been helpful to you this morning. It is a bit of a whistle-stop tour through eczema, but I'm happy to take any questions. Thank you for listening.
Thank you so much, Odette. That was really great. It was really concise and really interesting to listen to that step-by-step approach that's needed. We are going to welcome into the conversation now Dr. Anjum Growell, and over the next 30 minutes we are going to be here as experts in a live panel, taking questions that have been presented to the Slido platform by those live streaming. And there's been over 100 people listening into the conversation this morning, which is fabulous. And the first question I have is for you, Dr. Anjum. And one of our listeners has asked the question, regarding facial eczema in small babies and children, and kind of wanting to know what the next steps are with parents after they've been using emollients, good quality emollients, for a long time. What are the next steps? We see, facial eczema in babies and young children quite commonly. So what advice would you give to a healthcare professional that's posed that question?
Thank you. Okay.
Yes.
Can you hear me okay? Wonderful. So facial eczema is extremely common in babies, just like you've said. And there's a couple of reasons for this. First of all, that's the natural course of eczema to start on the face. But also, secondly, face is one of those areas that come in contact with the environment a lot. With babies, especially when they're weaning, trying different foods, rubbing things over their face, and salivating, using dummies, that's said. So there's so many factors. It's important to understand why is the eczema getting a bit out of hand on that particular area, and try and manage that, alongside loads of moisturizers, as well as the barriers that Odette mentioned as well. And once you've done that, because the facial skin is quite thin and delicate, the mainstay of managing inflammation following the would be to use mild topical corticosteroids. So my personal preference would be hydrocortisone %. Ointment is quite good to use. It creates a barrier as well. Some dermatologists prefer to use sometimes because some of these facial lesions can have fungus in them. So having that as a combined method to cure the candida as well as inflammation is good. The other thing I'd like to mention is, as these children then get older, some of them have quite resistant eczema around their eyes. So periorbital eczema can be very difficult, as can perioral or lip dermatitis. For those patients, I would suggest starting off with a topical corticosteroid like hydrocortisone, but then trying to move on to calcineurin inhibitors such as pimecrolimus. That can be really, really useful, and steroid sparing as well.
Excellent, thank you. I think there's some really strong advice there in managing those tricky areas, especially in the infants. And just going back to a point that Odette made, that area is very sensitive when those infants start weaning around 6 months of age. If there's prolonged contact with foods around the face, particularly those foods that are high in histamine, so things like tomatoes and berries, then that can aggravate eczema skin, but it can also aggravate sensitive skin. And parents can often think that their child's having an allergic reaction, and that isn't the case. It's the fact that they have that contact reaction through that prolonged exposure to food. So it's important to keep that area clean and dry. You can use the ointments around the face as a barrier to protect the skin as well. Okay, so moving on, we have lots of questions here. This question is for you, Odette, and we have one of our live stream participants asking about the benefits of bandaging, and you talked about it briefly in your slide, but their specific question is, at what stage would you consider bandages to be helpful?
So I think bandages can be helpful for children who potentially have sort of moderate eczema upwards, really. The garments are really very helpful because they are available in sort of vests and leggings, and they make it really easy to use. So you can apply your moisturizer, put the bandage on top, and it actually keeps everything in place. Because I think sometimes we get really worried about the moisturizers making a mess, particularly with the greasy moisturizers. So they definitely have their place in being used. I've also used sort of cheap cotton baby grows to do exactly the same thing. So, you can use them at any stage in the eczema trajectory. It's just working out what's going to help the family that you're working with the most, really.
Excellent. Yeah, I think that's a good point. And often people think they have to spend a lot of money on, treatments and things. You've got.
I've gone into the dark. Sorry.
Okay, we can see you again. Lovely. So we've had a couple of questions in around environmental triggers for eczema. and I'm happy to pick up the kind of response to this, because it's a question that comes into the helpline at Allergy UK commonly. So people talking about their living environments being quite damp, so the housing, bedrooms, etc. And does that have the potential to impact on eczema? Absolutely, it does. So there's so many environmental triggers which have been pointed out by both Dr. Anjum and Adet. And they have a real impact on the control of eczema and the fact that they can be a flare. So if children or adults are living in damp environments, spending large amount of time in environments that are damp, which have the potential to provide mold spore exposure, then that can be a significant trigger. And on the Allergy UK website, we have a fantastic fact sheet on mold. So I'd encourage you to have a look at that, because it has some really nice information there about reducing exposure, the kind of tips and tricks you do. And a lot of the time, it's down to promoting good ventilation in those particular rooms. But it definitely can have an impact. And where it is out of the control of the family, for example, if it's in a rental property or in social housing, then it may be that you have to liaise with people from the housing associations or the landlord to look at those particular issues if they're having a significant impact on their health. Do you have anything to add to that?
Could I add a couple of things there, Holly? Two things. One, when people mention the difficult to treat eczema in exposed areas, then definitely the environmental allergens must be considered, dust, mold, etc. And this, again, the facial eczema that someone asked about, so that's one of the triggers. But the other thing is I wanted to just quickly mention about airway allergies. Molds and dust and other environmental allergens are a big risk factor for developing difficult to treat asthma. So it's really important that we get them under control.
Yeah, that's great. Thanks for bringing that in. That's a really important link, isn't it? Because those triggers are very prevalent in respiratory conditions as well. So thanks for bringing that into the conversation. My question now, I'm going to ask you, Adet, and it's with regards to the itch associated with eczema. Do you have any tips, and is there a role for antihistamines in managing the itch of eczema?
So antihistamines, unfortunately, generally don't do anything for itch and scratch. So it's quite difficult to manage, because I know some people like to, in babies, try the Piriton or chlorphenamine because it's got the sedative effect to it. You might get the sedative effect, but you're not going to stop the itch and scratch. So having things like, I particularly like things like the sleeves with the mitts on the end that can cause less nail damage. So, and a good topical steroid if needed, lots and lots of emollient, but making sure how you're applying your moisturizer, because if you're struggling with itch and scratch and you're either yourself or your child is rubbing the creams vigorously, then they might be making themselves extra itchy. Letting them cool down after a bath a little bit before you put on the moisturizers, or using the moisturizers out of the fridge so that they are much cooler, can sometimes be really effective. But you often have to do a bit of behavior modification, because once you've learnt to scratch, it becomes a habit. And once it's a habit, you don't have to think about it anymore. So often doing good topical treatments, so along with a little bit of behavior modification, can reap really, really good results. But generally children scratch less when their skin is well controlled.
Great tips there. And I think distraction as well is a key, isn't it? Distracting the child by play, by watching something, listening to a story. So there's lots of different techniques there, but I think the key thing about eczema is the itch, isn't it? It's such a debilitating symptom for these infants and children and adults, and can be so distracting, can't it, from their schoolwork, from whatever they're trying to apply themselves to. So if as parents we can get on top of that, we can manage that, then ultimately it's going to help them.
I think the other thing with itch, Holly, is if you can have a way of encouraging children to use their moisturizers, so sticker charts, very, very small free rewards, you can use that distraction to apply the creams to then give them a little reward at the end of it, even if it's only a sticker or a smiley face drawn on a chart. Those things can be really, really helpful.
That's a great idea. That's a great idea. What I may use at home. This is a really great question, and I'll direct this one towards you, Anjum. One of our clinician colleagues has asked, in eczema herpeticum, roughly how long after starting antiviral treatment can topical steroids be restarted?
Yeah, it's a difficult one because eczema herpeticum often does flare up in the context of poorly controlled eczema. So the two things are often going together. And just as Odette said, not all oozing and crusting will respond to the antiviral or the antibacterial treatment that we provide. So our antiviral course is usually 7 to 10 days. 5 days if it's a very small area of involvement. And once all the little ulcers and the blisters have cleared out, that means there's not much virus left on the skin, then about a week later, it's safe to start using steroids again.
That's great. That's really helpful. Thank you for answering that so succinctly. We have a question here on washing and bathing, and I'm happy to jump in and answer this. And it's a really good question, actually, because we assume that everybody has a bath at home, and many people don't. I can see Odette nodding her head here. A conversation she probably has on often occasions with patients. But the question is it the same to soak the skin in the shower? And I would say absolutely. You use the means that you have. If you have a bath and your child enjoys having a bath, then absolutely fine, continue with that. But if a shower is what you have, then there is ways that you can still provide cleansing of the skin and help to promote cleaning of the skin, reducing that microbial load, all the things that we want bathing to do. And again, it comes back to optimal conditions, so not having the water too hot, not allowing that shower to be too prolonged. What I did when I lived in a flat and had a small baby was I bought one of these fold-up baths, and I kept that under the bed or in the back of the wardrobe, super easy to store. And I popped it up and put it in the bottom of the shower tray and let the water fill up and put some water in. And you had a nice little cubicle in the bottom of your shower. So there are ways and means around still being able to bath within a shower facility. So absolutely using a shower, using a bath, but sticking to the key kind of messages around bath. And it's good to bath eczema skin. Doesn't need to be daily. It can be alternate daily. And keeping the water warm but not too hot. The frequency under 20 minutes. And applying a good quality emollient and using a soap substitute in the water. Is there anything, Odette, that you'd like to bring in to that kind of answer there?
I think showering is fine. We have a lot of people who don't have baths, so using the soap substitutes on a sponge, getting a lot of water on the sponge and making sure it's going on the skin quite frequently. But again, it's difficult because you have to use the means that you have. So it's probably not going to give you quite such a good result as having a soak in the bath, but equally you can get really good response.
Yeah, that's great. And it's, of course, a personal choice, isn't it? Not everybody likes to have a bath. And, the weather's been so hot lately, it may be that you choose not to do that. That actually leads really nicely onto a question that somebody's posed around a soap substitute called Dermol, which is commonly prescribed as an antimicrobial emollient soap substitute. And the question is with regards to, really the use of this and whether it should be put on a repeat prescription in mild eczema with no previous infection. Is it suitable? Is it safe? Was the question. It's commonly prescribed in primary care.
Would you like me to take that one, Holly?
That would be great, Anjum. Thank you.
Thank you. So Dermol or other similar substances which have antimicrobial or antiseptic properties they have a specific purpose. The purpose is to reduce the colonization of the bacteria, reduce the frequency of infections, and keep the skin bacteria free or reduce bacterial load. So first of all, in mild eczema, we would not expect there to be extensive colonization, and there isn't a need for these products. The need really is for moderate to severe eczema when you have demonstrated frequent skin infections. Otherwise, even in those conditions, you don't particularly need any antiseptic products. The danger with using antiseptic products to a skin that doesn't particularly need them is that they have chemicals in them, such as chlorhexidine, benzalkonium, etc., that then the child will become sensitized to. So I think it is unnecessary when you don't have frequent infections, and there isn't much of an advantage to using it.
That's great. That's really helpful. And you actually answered a second question, which was about the sensitization of chlorhexidine through the sensitive or broken skin barrier. So that was a really succinct answer. Thank you so much. I'm going to keep you in the conversation, Dr. Anjum here. I've had a question with regards to patients experiencing skin colour changes due to their eczema treatments. And the question underlying this is, does the skin colour ever return to its normal natural colour?
So in answer to that, there are a few things to bear in mind. First of all, it isn't the treatment of eczema, but the inflammation of eczema that causes skin color changes. And if the skin color has changed, it suggests that there was a chronicity to it. And also it can suggest that that underlying skin, the kind of skin that person had was more prone to changes. So certain ethnicities, for example, can have more significant color change with eczema rather than others. And equally, certain ethnicities or certain skin tones will have more predilection towards a longer term skin change. So we can try and prevent the skin change by managing the eczema adequately and preventing the chronicity. But it's very difficult to predict which of these colors will then go back to merge into normal and which wouldn't. I suppose a helpful thing would be to continue to moisturize and use sun protection to prevent further skin color change. But effectively, once the skin color change has happened, it's hard to predict which ones will then go back to normal and how long in. Would you agree with that, Odette?
Absolutely. And I think the reassurance that it's not the topical steroids that have caused that paleness is key to families, because sometimes I often see that if they lose the color during the spring months, they'll get a bit of a suntan during the summer months, which makes everything look more prominent. And then you almost need them to fade back to their winter color and repigment the following year before you see some changes. So it can be quite an extended period of time before you see some improvement.
Yeah, great. I would agree. Yeah, absolutely. So moving on to questions about emollients, and there's been a few here about emollients that potentially contain food proteins, so things like oats, coconut oil, olive oil. Sometimes people prefer to use emollients containing these. Do we have concerns as clinicians about these? And if that's a person's choice, what kind of advice would we give around the safe use of them? Dr. Anjum, I can see you nodding there, so it's a question that I will pop to you in the first.
Yeah, so I guess this is actually a fair concern for us as pediatric allergists, where there's such a big wave and epidemic of food allergies, and we really want to try and prevent them. What we, as Professor Carsten mentioned in his talk as well, what we know is that the broken skin barrier can become a gateway to the immune system sampling food proteins and then potentially becoming allergic and sensitized to those food proteins. And that is one thing we are very, very keen to try and reduce. So obviously, while we are trying to tackle the skin barrier to becoming more resistant to these kind of sensitizations, it's equally important not to apply onto the skin any food protein that isn't already ingested. So the dual hypothesis of development of allergies suggests that if a protein is sampled through the gut which is the natural way of sampling proteins, then we are more likely to become tolerant to it as infants. Whereas if the same food protein is sampled first through the skin, then it triggers the wrong Th2 pathway and makes us develop allergies. So the use of all creams and skincare products, or even parents' hands with certain types of food proteins that are not already a part of the infant's diet, is dangerous and can potentially lead to long-term food allergies. So I would suggest that if they want to put a particular product on their skin, it should be free of food proteins unless they are regularly consumed in the diet.
Absolutely. So that means that those infants that haven't started weaning, that's particularly pertinent to them. So those babies that are developing the mild to moderate eczema in the first few months of life, that's really, really important messaging to think about when talking to families when prescribing emollients. Along the lines of topical treatments, this is a common focus and a common question. So I'm sure that you're very well posed to answer this, but we have somebody that's asked the question about parents that are reluctant, hesitant to use steroids to treat their child's eczema. Can you offer any tips of advice about the kinds of conversations you have, or the kinds of things that you would use to reassure those parents, so our listeners have something to bring into a conversation there?
So I think the topical steroid conversation is always really tricky, because we're all in a situation where you want to not use topical steroids, but I talk about them as anti-inflammatory treatments. And the only thing that's really going to treat an inflamed area is an anti-inflammatory treatment. So I think if you change the way you talk about topical steroids, it takes the focus off it a little bit better. I work every day with children with allergies and eczema, and the conversation about topical steroids is probably 3 or 4 a day. Some people will be very happy to use them. Some people will be very resistant to use them. And I think you have to listen to their concerns, take on board what they're worried about, and then try to offer a solution which is going to both treat the eczema and deal with the worries and concerns related to it. So it's never an easy conversation, but I think if you tackle it in a way that the anti-inflammatory properties of a topical steroid are going to work, then you generally will get people on board. And I often ask people to give me 6 weeks. Give me 6 weeks to try and get this eczema better. If I can't get it better in 6 weeks, then fair enough, you can make your own decisions. But generally, if I can get them on board, I get their trust, we get it better, and things are easier to manage.
I think you've brought some really interesting points to the conversation there, and the big thing for me is that explanation to the parents of what eczema is, that it isn't something that we'll find one particular trigger and we remove that and the eczema clears up. It isn't a disease that we're going to find one particular treatment and it's going to resolve it. It's about combinations. It's about an individual holistic approach, and it's about them understanding how the treatments work and understanding about the possibility of all the different triggers we've talked about, and trying to establish what some of those might be. So there's lots for parents to take on board, isn't there? But I think I like the fact that you kind of talk about trust and those things, because that's what parents need to hear. They need to have trust in the people that are caring for them, and confidence as well. So I think that's really important. Dr. Anjum, do you have anything that you'd like to bring into the conversation there about the steroids?
So I have a very similar conversation with my patients as well. And I do sometimes throw in the food allergy side of things, where if I can manage the skin, they're less likely to develop more and more sensitivities and allergies with time. And also that using a tiny amount, because sometimes what people do is they sparingly use topical corticosteroids where they think they're using them, but actually they aren't. So they aren't seeing the benefit because they aren't using enough to manage the skin. So using tiny doses for years and years is not better than using a good dose at the right time, get the inflammation cleared, and the child is more likely to grow out of their eczema sooner.
Yeah, I'd agree. Education is so important, isn't it? And just going over what people are doing and establishing how they're using it in the correct amounts, going through the fingertip units. There's quite a lot to take on board there. One of our contacts has asked the question whether you need to monitor adrenal suppression for children that are having steroids in various strengths, and I guess this may be more for children that maybe have concurrent asthma and are having some inhaled or oral steroids as well. What are your thoughts there, Dr. Anjum, on the need to monitor for adrenal suppression in children with regular topical steroids?
So I think the first thing is it's important to understand that steroids can cause a number of significant systemic side effects, adrenal suppression, growth suppression, etc., being one of them. But if you have a child that requires so much steroid for a longer period of time, it's important to think, have we got the management right? So these children who have required moderate to more potent steroids for a number of years, so we are thinking of moderate to high potency steroids for more than 3 or 4 years, or actually potent steroids for potent or very potent steroids for anything longer than 3 to 4 months, then it's important to take a step back and say, what am I doing here? Does this child need to be escalated to a secondary or a tertiary care specialist? Equally, using oral steroids for eczema. I think in a primary care practice, mild to moderate potency steroids for short periods of time should suffice. If a child needs anything more than that, they should be under a specialist who will then also monitor for adrenal suppression and growth suppression.
Great, thank you for confirming that. Now, I've had a couple of comments on the Slido platform, and this isn't particularly questions, but I'd like to address them. People just asking, they've missed a couple of slides out of presentations because they had to step away from the computer. And just to reassure you that if you do want to re-listen to this, this masterclass, you are able to do so on the Allergy UK website under the healthcare professional section. This live session will be available on demand. It may be available in a couple of weeks' time, so just log back in then, and you certainly will be able to catch up on the sections that you missed. Okay, so I think that concludes the Q&A session. Thank you so much to our panel that have so eloquently answered all of those questions. Thank you very much for your presentations as well.
Thank you, Holly.
You're welcome. So that concludes today's masterclass, and I'd just like to offer a very big thank you to all of the hard work that goes on behind the scenes here at Allergy UK, and also with our partners at Attendable for providing the platform to put on such a great live event. Thank you also to our corporate partners whom, without their support, this event wouldn't have been possible. Move slide, please. So just to reinforce that you can claim CPD points for attending each live session, and we will provide a survey so we gain some feedback on this event, and once that's been completed you'll be able to receive your certificate, which is really useful for revalidation for your nursing practice and for other specialities as part of your CPD log. And as mentioned before, you will be able to access the information on here, tell your colleagues about it, anybody that's interested in it. As long as they're a healthcare professional, they'll be able to access the content. Slide forward, please. So if you are interested in listening to live streaming or accessing on demand any more information on food allergy or weaning of infants, this was the first of a 3-part series launched this autumn. And the next session will be on Thursday, the 19th of October. It's a bite-sized session, really great at lunchtime, and will be chaired by my colleague Lydia, who's a research dietitian, and she'll be having some really great conversations on weaning and food allergies. So that's one not to be missed. And again, we'll be returning in November to address food allergy. So a really interesting presentation. We'll have some great experts there to share their knowledge, and that is a full-size masterclass like this one this morning. Next slide, please. And that formally concludes today's Eczema Back to Basics Allergy UK hosted masterclass. Thank you very much.
Okay, we're all clear.